I want to welcome everyone to Palliative Care. We've done this about 2 years ago. We brought a doctor in from Massachusetts General, and this palliative care is interesting because, well, first of all, let me introduce myself. My name is Mark Rosenzweig. I'm from West Bloomfield, Michigan, and this is my 11th year in having ALK-positive cancer. But I've only had 2 appointments with a palliative care doctor, and it just happened a couple months ago. And I got to a point where I just couldn't handle the pain, so and the neuropathy. So I seeked out a palliative care doctor, and I know we kind of covered it a little bit in the summit. I want to give a shout to Kirk Smith. Kirk, I'm where you're at. Live, buddy, live. So, anyways, and that's really about it. I think this is a great topic, and I welcome everybody. And I'm, as usual, we'll do some polling questions. So here we go. What is your treatment that you're receiving at this time? And Summer, as usual, for the recording, you're going to have to give the responses.
I sure will. And as you answered that, I am Summer Farman. I'm from Hershey, Pennsylvania, stage 4 ALK positive patient since summer of 2020. Okay, what type of treatment are you receiving? 63% of you are on alectinib, 22% lorlatinib, 8% are brigatinibers, that's me. Chemo and a TKI, 6%. We have nobody here tonight that is on chemo. And Mark actually is in a clinical trial, but for the polling purposes, it says 0%. And you'll see that palliative care is huge in managing side effects. So the chemo people, you're really missing out because palliative care could be a huge help for you. Okay, Mark. How do you rate your quality of life? Are you feeling great? Back to your pre-cancer baseline? Pretty good. This is my new normal. Tolerable, realizing I have some new challenges. Barely hanging on. I need assistance in daily life, or bedridden, unable to live daily life. I personally, this is my new normal. Some days I'm feeling great. I wouldn't say that I'm back to my baseline, but yes. Okay, the results are in. 55% of you are in the same boat as me. You're pretty good. This is your new normal. 29%, it's tolerable. You realize that you have some new challenges. 12%, you're back to your pre-cancer baseline and feeling great. 4%, you're barely hanging on. I need assistance in daily life. And luckily, no one is bedridden. So that is definitely a plus. Thanks, Mark. Yep.
Okay.
Now I do. How did you hear about this session? From our support group. This is a great one. From the website, social media stories, which we did a ton of. So be sure to check those out and subscribe to the Instagram and Facebook. It's different from the support group. Or our newsletter, which we've been pushing this one for a while. Okay, let's see here. Hold on, guys. Let me get really close. 56% of you heard about tonight's talk from the Facebook support group. Awesome. 23% from the newsletter went out. Good to know. And 21% of you from the website. Fabulous. The stories, they are there and are heavily advertised. So check those out as well, please. Katie, make note of that. Okay, when were you diagnosed? I can't answer, but I am at that 3.5-year mark. And Dana, I think, also can't answer. She's right at the 3-year, just celebrated in November. Okay, survey says, let's see. 1 to 2 years, 29% of you. 2 to 3 years, 20% of you. 3 to 4 years since diagnosis, 14% of you. 10% of you are 4 to 5 years. Also 10% are under a year, so welcome, new Alkies. And 6 to 7 years since diagnosis. 4% of you, sorry, I'm really sorry, everybody. I totally went out of order. I didn't see this, that I could scroll here. 8 or longer, Mark is included here as well, 12%. So I apologize for that. But there we are. Okay, this again, why we had this topic, such a misconception and an untapped resource. When you think of palliative care, when you hear, what do you think when you hear the word palliative care? I'm dying, hospice, physical, emotional, social, financial support during my cancer journey, or I'm not really sure. I don't know. Okay, so good to know. 65% of you are right on target. Awesome. Physical, emotional, social, financial support during my cancer journey. Ding, ding, ding. You've won. Good job. Okay, 17% of you are not sure about palliative care, what exactly it is. So glad you are here. 10% of you, oh, heck, I'm dying. And 8% of you put palliative care and hospice together in the same boat. A lot of people do that actually. So, all right, that is good. That gives our guest speaker, some background knowledge.
Dan Wilson is my partner in crime when it comes to the men's club meeting. And Dan is being treated at Thomas Jefferson, I believe. And Dan, take it away. Where's Dan? Dan just had a new baby, by the way.
You gonna let me say anything for myself, Mark? Or
no, nothing. Go ahead.
Good evening, everybody. Welcome. My name is Dan Wilson. I'm from outside of Philadelphia, Pennsylvania. And I was diagnosed 5 years ago. So recently celebrated my 5th anniversary. Quite exciting. Creates a lot of hope for others and people ahead of me. Outliving ALK-positive cancer is definitely a big boost for all of us in our journeys. So as part of my care, very early on, I was introduced to palliative care. Very much like many of us in our group, I had no idea what it was, who I was going to be speaking to, how that would become part of my journey at that time and in the future. But I had a wonderful care team that I was introduced to, and she's here tonight. At the summit this past summer, an individual from her team, Lauren McGrath, was available during breakout sessions for those people who were live. Again, Lauren is part of Dr. Brooke's team. Without further ado, Dr. Brooke from Sidney Kimmel Cancer Center, Jefferson Health.
Hi, thank you guys so much for having me. It is lovely to be with you tonight, and I'm glad to see all of your lovely sort of happy faces here. I promise, I think I'm not so scary of a human, and hopefully as we have a conversation and talk a little bit about what palliative care is, but more importantly, what I think is important for you guys to know, to feel empowered and as much in control during this sort of space where cancer takes a lot of control away from you. I think that's kind of what the main goal of palliative care and any of my conversations with anyone is. But a little bit about me is I live in Center City, Philadelphia, and I am a physician at the Sidney Kimmel Cancer Center. Happily, about 50, well, not even 50, about a part of my time, I'm seeing patients in our what we call supportive oncology, which is a sort of large group of pain management physicians, palliative medicine physicians, cancer rehab physicians, psychiatry, nurse practitioners, nurses, social workers, financial advocates, nutritionists. Sort of, I tell everybody it's everything except your cancer treatment that is there to support you and improve your quality of life. And the other 50% of my time, I do clinical cannabis research in cancer patients. And so happy to throw that topic on the table too, if anybody is interested or has questions about cannabis use during their cancer journey, because I kind of got into all of this space through you lovely patients asking me lots of questions that I didn't know. And so that has been kind of the journey into cannabis and how I first met Dan. My background is that I am an internist, so kind of general adult doctor initially. And then I did my fellowships up at the Harvard system at Mass General and Dana-Farber. If anybody's calling in from Boston, hello. I loved living up there too. I did a fellowship in pain medicine first and really fell in love with the cancer patients, and then did a second fellowship in palliative medicine because I really wanted to specialize in cancer patient population. And so that sort of led me down to Philadelphia and kind of into the space of palliative medicine, which I think the biggest misnomers, and thank you all for being very honest in that polling question, is that most people don't know at all what palliative medicine is, or they sort of immediate, or palliative care, kind of immediately associate it with hospice. And that's probably because, you know, we haven't had a great marketing team, frankly, across the cancer space to sort of say what this is, but also because it's sort of a scary thing when you get cancer and people toss a whole bunch of stuff at you, and you Google things, and Dr. Google, you know, talks about all kinds of stuff about cancer treatment. And I think a lot of that stuff feels overwhelming and ends a lot of times with that dreaded H word of hospice. And so people tend to shy away or sort of not want to think about that, which I get. I wouldn't be any different. I am certain of that. But and I'm going to share my screen just a little bit here to talk through a little bit about some generalities of palliative care and what I believe it can and should be in your life. But in reality, please I open up the microphone to all of you now. I would love to have this be conversational and questions, or ask them in the chat, and whether it's Summer or Dan or someone or Mark will toss those questions out to us. But I'm going to share my screen. Here you go. And just a little bit, I want you guys to think about this in terms of what is palliative medicine, or what is palliative care. It really is something that is meant to improve your quality of life. I say to patients all the time, cancer sucks. And it takes so much control out of your hands in terms of what is happening to you, what is being done to you, what medications are being given to you, what schedule you are being tossed into, all of that stuff. And what any palliative care team that you will interact with, I promise this, will encourage you to feel empowered to say, here are the things that are important to me, and here is what I am okay with, and here is what I'm not okay with. And so one half of what I try to talk to all of my patients about is feeling empowered, and feeling in control as much as they can, and talking through sort of what makes them feel empowered, and what actually sort of makes them feel scared or less in control than they would like, and sort of seeing what we can do to alter that. And the other half of it is really, in terms of your quality of life, is how are you feeling? Right? I mean, I'm sure you all have wonderful cancer centers and amazing oncologists, and a lot of their brain space is always on, importantly, what they're doing about your cancer, which means that there's a heck of a lot of side effects that occur either because of your cancer or because of your treatment that sometimes don't get a lot of breathing room in those conversations. And so that can run from pain. I know Mark mentioned pain. That's a common one, but it can also be, I don't know, my sex life is really impacted right now, and that doesn't feel great to me. And I want to feel pretty good. And I was happy to see that a lot of you guys are feeling pretty good and sort of figuring out what new normal is. But sometimes, or a lot of times, we don't necessarily talk about things like, how has cancer affected your sex life? How has it affected your body image? How has it affected your sleep? Are you sleeping? Are you eating? Are you enjoying eating? How's your mood? Maybe you're not, suffering from a major depressive disorder, but maybe you are occasionally having significant bouts where you find it hard to be motivated to do your job or to interact with your children or, sorry, um, or your partner, or you get really frustrated really easily when people that care about you are asking things, or you feel really isolated from people that care about you because now all of a sudden you have something that they just don't understand. So I would say probably one of the favorite parts of my job, and one of the things that I hope you guys will feel empowered to ask to talk to, a member of your cancer center or treatment team that is sort of on the palliative care or supportive oncology side, is to think about, what is it that's bothering you the most in terms of your symptoms? Are you just and then kind of, how can we help get that improved, right? I have a lot of people that say, I just have tremendously crushing fatigue from my treatment or from my cancer, and I want to work, or I want to run, or I want to, it's not like we're talking about, people necessarily that are always really kind of having trouble doing daily activities of daily living. Sometimes it's above and beyond. And sometimes it is activities of daily living that you're struggling with, right? And it is really hard for me to, get out of bed and get dressed and feel comfortable. And so whatever it is, whatever the diagnosis, our goal is to improve the quality of life for you and for your family. And one of the big things I remember talking to Dan about, and Dan's family, his wife, his parents, his in-laws, all of that, is like, unfortunately, the other part of cancer is that it's a little bit of a team sport, right? And that you, as the person diagnosed, are going through it, and it impacts all of the people that are around you, and it impacts them in different ways. And so opening up the conversation sometimes about how is this affecting each of us, and how are we sort of making sense of it in different ways, is a really, I think, important part. And all of these things are just often things that don't get a lot of breathing room when you're doing all of the important conversations with your cancer doctors, right? So your medical oncologists, not that they're not amazing, they have a lot on their plate. And so sometimes it feels nice to talk about this, or to have space where, any of these things are the sole topic on the books. So that's sort of what we do. And to sort of give you a sense really briefly here, like, what's the difference between hospice and palliative care? And this is where I want you to think about it. Like, old concept, when this was kind of coming about, and it felt really scary, and nobody talked about cancer making you sick, or God forbid dying, was that, we focused on curative care, and all of a sudden it was like there was this wall, right? Or this big moat. And at some point, in some scary way, you either were tossed over it, or, fell into this space that all of a sudden things weren't curable, and now it was palliative care, or maybe people were immediately talking about hospice, and then, in some period of time it was death, and that was it, right? And so now the way that we think about taking care of people, and one of the big things and the reasons why we do this and why it matters, aside from just having better quality of life, but it matters because we've done good studies that show that when we pay attention to what are called PROs, or patient reported outcomes, you all feel better and you all live longer, right? So this is a big deal. It's not like it's nice to have. It's more like it should be mandatory for all of us to do this, because the more that we make you feel better, the longer that patients live with their cancer, right? So down here at this brown arrow, where it's kind of at the time of diagnosis, think about, that's the time when we should be talking about what is bothering you, what is making you sort of have a less than ideal quality of life. how are you feeling emotionally? Because God knows your head is attached to your body, and that doesn't get a lot of breathing room at times, right? But the more that we focus on your important outcomes, the better you're going to do. So think about it like this, where it's this line of, I'm doing amazing. You don't need to see me all the time by any means. No one wants to be over doctored, but as this, and I would make the argument that, this probably certainly isn't linear anymore, this line down here on the bottom. It's a little bit more like up and down and up and down and up and down, depending on the day of the week, the month of the year, the treatment that you're on, whatever's going on, you might need it a little bit more or a little bit less, right? And so it exists in conjunction with all of the other treatments that you're getting. And that team is wildly interprofessional. And I'm happy to keep talking, but I would really love to answer your questions and have a conversation and hear your thoughts about how often you've been exposed to this, what your questions are about palliative care, what your thoughts are here. Because I can talk or toss a lot more data at you, but I think it's really important for you to feel empowered in this space. And I would love to hear your questions.
That was a great intro, though. So at least that kind of helps us all understand what exactly palliative care is and how you are an active participant on our cancer team. I know when I was first diagnosed, they did the right thing and gave me a palliative care folder. However, and recommended me reaching out. However, it was like during the pandemic, palliative care was hopping on TikTok for some reason. So right before I was diagnosed, I had seen a bunch, which is great for education. However, I totally had a misconception.
Yeah.
And was so offended and taken back and distraught. And I think it was at least 9 months or so. And really when I needed it was more in the beginning, for sure. So I think that was a great,
And it's different for everyone, right? I mean, I think the biggest thing that I say, not but I try to say this to everybody, is that like whatever you're feeling is normal. And whatever you're experiencing and whatever your trajectory is normal. Like there's no such thing as right or wrong. What's most important is that, your normal is being heard and you're feeling like you have a space to talk about that.
Well, and ultimately for me, it took me entering a palliative care study. So that was what made me go. But now my advice to everyone is like, just go. Even if you're feeling great, just make the appointment. Then there's somebody who sees you at baseline and you can check back in and out. And so for sure. And we do have some questions. Definitely people want you to hit on the cannabis topic, but I don't know if you want to first start. There's some fatigue questions in here coming in, nutrition, swelling. So there's a bunch of different things we can cover. I don't know. What do you prefer? Do you want to go with the cannabis now or do you want to stick?
Yeah, I'll talk about, please. That's like always what people want to talk about. And I get it. It's how the first time I met Dan, right? It's like, that was like the non-scary way that they said for him to come see me in some ways. So let's talk about cannabis for sure. There's a whole lot that we can talk about with this. So guys, toss out those questions and what you want to know. But here's sort of the quick and dirty is that absolutely in a kind of, palliative way, cannabis can be extremely helpful for patients depending on what symptoms you're having. And the biggest part about it is that cannabis isn't cannabis, meaning it's not like it's all the same thing, right? There's a million different formulations, compositions, potencies out there, and a whole bunch of different ways that you have to step through different processes to get access depending on your state. Some much easier, some not as easy. The three biggest areas where I see and recommend and talk to patients about using cannabis is pain, any kind of pain or neuropathy, either from your chemotherapy or immunotherapy or anything like that. And there is a large subset, and a lot of our clinical research is in this space. There's a large subset of patients that say cannabis is tremendously helpful for pain for me. And a good percent, about a quarter of people say it's more effective than the opioids that they've had. And some say it's equally as effective, but it's a good tool to have in your toolbox. And the other two areas that I will say, actually probably three, but one I'll lump together. The second is chemotherapy-induced nausea and vomiting, or just nausea and vomiting in general, right? Tremendously helpful, incredibly underutilized early on. People often struggle, and then it gets talked about or thought about after they really sort of are on a lot of other medications or just really not doing well in terms of a nausea, appetite, vomiting perspective. And the other one is kind of the anxiety and sleep. And I'm lumping them together because so much of sleep or not being able to get good sleep is related to my mind is going a mile a minute and I can't relax. And so all of those spaces can be incredibly helpful with cannabis. The two big parts of cannabis to think about is THC. THC is the part that gets you high, right? That is the part that crosses into your brain and gets you high. It is incredibly helpful in some of these instances in certain amounts, and it varies a lot about where you start depending on if you've used cannabis before or not. Happy to answer any specific questions about that. It varies a lot in concentration of how much THC is in a product. And the other one is CBD. That is the part that doesn't necessarily get you high. It does cross into your brain, but it doesn't sort of make you loopy or high. And it does work in the periphery as a very significant anti-inflammatory agent. So it can be incredibly helpful for pain. There is a couple of Google and Reddit misnomers out there about cannabis that I will speak to right away. And then I definitely, Summer, if you want to toss out questions to me, I will answer specific questions. Two things. One is that we have no evidence, as much as I hope that down the line we do, but we have zero evidence that cannabis does anything in terms of treating your cancer. So please do not think that this is something that I would ever recommend as a cancer treatment. You have very good cancer treatments that your medical oncologist will guide you about. This can be incredibly helpful for symptom management and quality of life. If there is some benefit in terms of anti-cancer properties that we just don't fully understand yet, awesome, right? That is a great benefit that we all win if that's the case. But please don't overinflate what it is, because that's a big thing on Dr. Google. The other is there is this entity called RSO, or Rick Simpson oil, that a lot of people will ask me about. What that is a very specific type of or formulation of cannabis that, I don't want to get too geeky in terms of the chemistry about it, has been decarboxylated in a very specific preparation. It gets a lot of cred on like Google and in dispensaries and from bud tenders and stuff about it being like the thing for cancer. And this stems from, there was actually this gentleman who was a biochemist by the name of Rick Simpson, who was a Canadian and had a diagnosis of myeloma. He decided to treat his myeloma with this as a topical and posted his whole journey online and blah, blah, blah. And it looked like theoretically this was sort of causing his myeloma to get smaller or to do better. And kind of all of that stuff got put out there as this is the thing to use if you have cancer, or it has anti-cancer properties. In reality, we don't have any, actual good kind of clinical evidence about that. What it is often is a very, very, very potent form of cannabis that it has a ton of THC in it. And if you read online, the recommendations for how much to use and what the protocols are like scary large amounts of THC that kind of normal humans aren't going to tolerate very well. So if I can debunk one thing, it's please don't hang your hat that Rick Simpson oil is kind of what you have to be getting into. There are lots and lots of formulations of cannabis out there that can be helpful, but don't dive into that because it is not well tolerated unless you are a very frequent cannabis user.
You just pretty much answered a big chunk of the chat.
Awesome.
That
Awesome.
sidebar was going on like in real time. So that was awesome. So that's great. So for some people, Rick Simpson oil might be something you would recommend, but not to cure cancer. And it would depend on their habits anyway.
Absolutely. And honestly, if someone out there is saying like, I have used this and I tolerated it well, or it did great things for me, that's fantastic, right? That is a part of the space of cannabis, is that, remember, this is a plant. So it's not like me saying, I'm going to prescribe you 5 milligrams of oxycodone. And whether you live in Michigan or California or Pennsylvania or Colorado, that looks exactly the same, right? It just doesn't, because there's lots of different formulations or compositions. I would tell you that a sort of safe, tolerable sort of dosing that I recommend to my patients is never really in that higher range. However, I do try very hard to meet people where they're at. And if you have been a very regular cannabis user, you develop tolerance. And so, not unlike pain medications or anything else, that means you start at a different space than someone that has not been on it, right? So, I tell people this, it's sort of like if I'm prescribing an antidepressant to you, I don't necessarily know your biochemistry about which one will be perfect, right? But I can probably talk with you and talk about what side effects do you really want to avoid? What exposure have you had to any of these before? And pick something that's probably going to be pretty tolerable and might be pretty good right from the start. Same exact way I do cannabis with my patients, right? So think about it that way. It's a little bit about what side effects do you really want to avoid? What exposure have you had to it and how has that gone before? And then let's talk about the specifics behind how you want to use it. And there are things out there that can help guide you. Increasingly, there's access online to different entities and different using artificial intelligence and things like that. There's some companies that are really being helpful if you want guidance in the cannabis space for cancer patients. I can give you all that stuff too then.
That would be amazing. And also, like you're saying, side effects people want to avoid. As you'll see when we talk more straight palliative care and offering advice, people definitely want to avoid most the weight gain. That seems to be a common side effect, especially on 2 of our TKIs. So is there something? And so here's the thing, because again, these misconceptions with cannabis, and I am totally uneducated in this area, but maybe you can offer some of these. Most of our population is dealing with fatigue, massive fatigue, and also weight gain. So is there a cannabis that's right for them?
Great question. I will say for fatigue, there's really no evidence, and I do not look to cannabis for it, for fatigue. I will tell you, I'm a huge fan of the stimulants for fatigue, and we have tremendously good response when we use things like, you guys know, like Ritalin, right? Methylphenidate, or any of the things in that class that are really great, because that's the type of stuff that you can use when you need it or want it, right? It's not something you have to take all the time. You don't have to take it and have it build up in your system, but it can be incredibly helpful for, I'm going on vacation with my family and I want to be able to have a lot of energy to hang out with my grandkids or my kids or whatever it is. It is spot on. I use it all the time. Highly recommend this. Like, you'll know the brand names, Concerta, Ritalin, like all of those, they're great. They're interchangeable. A lot of it has to do with insurance. And so talking to your specific doctors about which one is the right one for you, do that. Big, huge fan, not cannabis in terms of the combating fatigue. There is especially a lot of cannabis products and strains out there that don't necessarily induce kind of the munchies, quote unquote, right? So where you got to be careful about is the amount of THC. We call microdosing with THC between 1 to 2.5 milligrams of THC. And in that space, it doesn't really ever trigger appetite or munchies. So I don't worry about that when I talk to people about this. And I say, listen, we're going to start you in that sort of range. And they make good products that have lower or sort of microdosing THC. And it can be incredibly helpful for the other symptom things we talked about. And I'm not worried it's going to sort of result in weight gain for you, right? Because the other thing that probably a lot of you guys have had conversations or thought about is weight gain really sucks with antidepressants too. And so that's one of the biggest questions I talk to people when I'm talking about treatment for anxiety or depression is weight gain a big deal? Because weight gain and sexual side effects are a huge issue in that. And so there's options that you can use to avoid it. But cannabis specifically, I would tell you, think of the THC on the microdosing side and you'll do much better.
So going back to the sleeping issue with indica as a strand, and then you
Mhm.
have sleep aids, Ambien, and so forth. And then, I mean, what questions would you ask for a patient? And what would you
Love it.
suggest?
Great question. And actually, the indica piece brings up another myth that I want to debunk in the cannabis space, which I'm going to do right now. This idea of indica and sativa is not, it does not hold true anymore in terms of like, if you get an indica, you're going to be tired. And if you get a sativa, you're going to be kind of more up. What that is it initially started because, cannabis is the genus and species of name of the plant, right? Cannabis indica, cannabis sativa. That is literally the genus and species name of the plant. And they were two very close, but like if you think about, like I tell people, think about a flower, like a poppy, right? A purple one versus a yellow one. That's like what those two differences were. Now the industry has grown to the point that there is so much interwoven and kind of crossbreeding that all of that is kind of debunked, and one doesn't mean one and one doesn't mean the other. It's really the composition of the phytochemicals in it, or the parts of the plant that are in it. Sleep. What do you want to think about? Here are the questions that I ask people, right? Because I think nothing is all right and nothing is all wrong, right? Like Ambien's right for some people. Look, lorazepam or Ativan or Klonopin, that's right for some people. Cannabis is right for some people. We can talk about it, but I ask, tell me about the sleep issue. Like, what's driving it? Is it difficulty falling asleep? And like, has this been longstanding? Has it been before cancer, or is it new, right? Because if it's since the cancer diagnosis, I almost always put my money on two things. One is, do you feel like your mind's racing? Like, can we just not kind of get your brain to slow down a little bit, right? Because that's really a huge deal. And the other is, what medicines are you on? Are you on a steroid, or are you on anything that's going to keep you up? Because those two things resulting from your cancer mean what I want to target is helping just kind of relax you or get you to feel very tired and fall asleep. This isn't like a lifelong sleeping disorder. It's because of that. And so in that way, I don't turn to Ambien. Cannabis can be incredibly helpful at bedtime for that reason. If it's, I need to relax, I want to get to sleep. That's also where I turn to things for people for a period of time in that benzodiazepine, SSRI kind of class, where it's like helping you just calm your mind down. And I don't think about the Ambiens and the things like that. That's more like I cannot fall asleep and I can't stay asleep. Like I wake up every couple hours, I'm tossing and turning. I cannot do this. Or I've had sleep problems my whole life that sort of predated cancer. And all of these things work in different ways. They all have side effects, and talking about what do I want to avoid, but that's sort of how I think about it. Oh, and I'm seeing someone about the sleep apnea. Dana, great point. Sleep apnea is another big issue in terms of like, how are we thinking about sleep and what are we doing? So that's another big question that I ask to people, because if you have sleep apnea, no matter what I give to you, you're probably not going to feel really good in the morning. You're still going to feel really tired if we don't either sort of diagnose or treat your sleep apnea too. So that's another kind of question that I always ask people in terms of the sleep.
Another question for you quickly is, a lot of our medications cause edema
Yeah.
and causes other things, side effects.
Mhm.
The palliative care doctor, do you consult with oncologists, or how does that work with, giving a weight loss, like a edema product to someone,
yeah.
like a LASIK or something like that?
Great question. And this is going to be really practice dependent, I would say. We are embedded, like literally physically embedded in our cancer center. And so, yes, I mean, I collaborate with the oncologist all the time, whether I'm like texting Jen Johnson, who's Dan's oncologist, or they're messaging me, or, we're communicating. We do it all the time. I think the biggest thing that I would say to you is anything that I think is going to have any interaction with your cancer or your cancer treatment, I'll make sure that there's no concern about it. So like for the edema, absolutely, that sucks. And that is a big deal in terms of quality of life. And I do it often. I give people a little bit of a Lasix or another diuretic, or make sure that they're not on other meds that are affecting or causing edema too. But I'll always just, quickly message their oncologist and say, hey, any reason why this is an issue? So I think in part of that empowerment side of my kind of interactions with you guys is like, ask, say, I don't like this. And who's going to help me with this? It's fine, whoever it is, right? But if anyone's doing it and it feels like it's like a little bit in a silo and not coordinated, it's always okay to say, hey, I want to make sure that we're all on the same page here. And if you get a no from someone, like I've had this where, not because the oncologist wasn't great, but just probably because they didn't know a lot about it. It happens with cannabis all the time, right? Where they said no or whatever. I've had patients come to me and say, my oncologist said no, or they didn't say it. I'll say, let's talk about it. Like, what's the issue? What's going on? I'll talk to their oncologist about it and say, look, what are you concerned about? And a lot of the times it's just like, I don't know anything about it. Like, I'm fine if you want to do it. I just don't know. Right. So feel empowered to ask for help with whatever symptom it is that's bothering you. And if one of your doctors is doing it in a way that feels like not everybody's kind of keyed in, also say that. Let's make sure everybody's on the same page, right?
Yeah, I think that the misconception is people think that their oncologists should be prescribing these meds, which in a lot of sense, the PCP can't even prescribe these meds.
Oh yeah. Oh yeah.
So
Guys, again, this is like why it matters is your oncologist is doing the work of making sure everything with your cancer is getting acknowledged, right? All the side effects of the drugs and the cancer and all that stuff, it just sometimes takes another brain or another space to talk through it, right? Like, it's not that they may, if you brought it up, they might, but it's also totally fine for a primary care doc or palliative care or anyone to prescribe that. Absolutely.
How about back to cannabis for a second? I have a couple dosing questions. One, just in general, someone who maybe doesn't have experience with cannabis, what would be a therapeutic dose for THC or CBD? Is that microdosing you were talking about, or?
Question. So the first thing to think about is, what form do you want to use it in? And what I mean by that is, do you want something that's inhaled? Do you want something that's ingested, right? The edible, the tincture, the things that you're swallowing.
And tell us what the
versus
tincture.
a tincture, it's an oil that you either put under your tongue or swallow. It's like an old-timey type name. I don't know why that's in the cannabis world, but that's what they call it, a tincture. In some states, the other thing that you're going to see are like beverage additives or beverages, like actual drinks that you can drink too, right? Any of those things, I would say the term that you should think about them is it's called an ingestible. And that means it's something that I'm going to put into my gut and it's relying on my gut to kind of break it down. The reason I say think about that first is because inhaled anything, and I would push you all if you're going the inhaled route, because I'm a doctor, I have to say this, nothing lit on fire and inhaled into your lungs is good for you. It's not like a cigarette, I get it, but there are versions that are vaporized, meaning oil gets heated and you inhale the vapor, and that's infinitely more tolerable to your lungs if you want to do something inhaled. But the onset of action of something inhaled is 5 minutes, meaning I'm going to take one inhale, I'm going to feel it quickly. The onset of action of something ingested can be up to 60 minutes. So that's variable, depends what's in your stomach, how you did it, 20 to 60 minutes until you sort of feel the full effect, right? So if you're stepping into the space, just be patient if you go the ingestible side. Because I've had people be like, I took a dose, I felt nothing. I took another one, and then whoa. So don't go there. The next thing to think about is what's the composition, or what's the sort of amount, just that question you asked. If you are kind of what I call cannabis naive, meaning maybe you smoked pot in college or you haven't had it in any while, but you're not using it regularly, the dose of THC that is going to be tolerable and not make you feel so high or loopy or anxious or dizzy or any of the things that you don't want is going to be a THC amount of 5 milligrams or less. I would say 5 is the high end of where I would go as a starting space. A lot of the gummies or the drinks or the things like that are often in either 5 or 10 milligram THC doses, right? So cut it in half if it's 10, or drink half the can, or whatever, right? Don't take more than 5. CBD, however, and this is where you're going to see, like, the products that are out there aren't necessarily well done always medically. They're meant to get people high, which isn't what you want. The therapeutic dose of CBD is more in the like 100 to 200 milligram dosing, right? But if you look at a product that has both of them in it, you're going to see you're going to get 5-10 milligrams of CBD, which often isn't going to do much. That's kind of homeopathic dosing. So don't be scared if you see a product that has CBD that is 100 milligrams, but be very scared if you see a product that has THC of 100 milligrams, right? So just as a way to think about it. Now, if you're using inhaled products, meaning a vape or the flower or whatever you're getting there, that's going to be written in percentages. So you're going to see it not as milligrams, but percent, like 40% THC, 80% THC, 30% CBD, whatever. Where a safe, tolerable starting space is keep the THC at 40% or under. You can always go up. I promise. You can inhale more often if you want. But if you start there, you're not going to get like to a space where you really don't like how you feel, right? And that's what I always say to people. Start low and go slow. It's kind of like I would never give you 500 milligrams of oxycodone as your first dose. But if we need to get there, there's people that get there, right? So start low and go slow.
Sorry to
Awesome.
That's my quick
deviate
and
from
dirty on the
the
dosing.
Wait, I know
cannabis.
I have one more right there for cannabis. Hold
Go
one
ahead,
second real
Summer.
quick. Thank you so much. Sorry, I just wanted to cover the other end of that. Is combining, somebody said, do you combine, they asked specifically about dosing, but 2 things. Would you combine cannabis with opioids, or would you combine cannabis with antidepressants? Like, do you use both simultaneously?
Fantastic question and incredibly important. The first time you're using it, anything that can make you tired or loopy or sleepy, right? Like your opioids or your benzodiazepines, like your Ativans or your Klonopin or anything like that, or alcohol, don't put them together at the same time, right? Don't like take that cocktail all at once, because that's where you can sort of really feel pretty sleepy or pretty loopy, okay? So I tell people space it out by 2 hours.
Okay.
As like a fair starting way to think about it. The antidepressant, if you're on it, have at it. Like, it doesn't matter. Those are so long acting in your system, and the half-life is so long, it doesn't matter. If you want to put it at that time or opposite, like, there's no harm there. So I tell people, don't worry. The other really nice thing is, in a couple things I want to say. There is no interactions with chemotherapy for cannabis. Okay. So it doesn't matter in terms of dosing for any normal amount that you're taking. Where I will tell you, and we are running a study that the National Cancer Institute's funded for 5 years and looking at a lot of cancer patients that are getting immunotherapy, is that high doses of CBD, just like Advil and ibuprofen and steroids, can potentially mute your immune response to immunotherapy. So that's where I want you to have a conversation with someone about doing it before you start taking hundreds of milligrams of CBD if you're on any kind of immunotherapy, okay? Because that's where we need to learn more. And I tell people, I just want you to be smart about this, right? We can certainly ingest lower amounts of CBD and we know it has no impact, but don't go to those higher ranges if you're getting immunotherapy. I think it's important to see how our immune function works.
Okay, sorry to break away from the medical marijuana questions, but I was shocked that you put down the last question, which was your question about financial resources that palliative care gives.
Yeah.
So this is a 2-part question. I'll start with the question from the chat, which is this woman was on Ozempic, and then it got taken off where it doesn't get covered by Medicare. So she wants to know, can you use a GLP-1 agent for weight in population gain?
Can you use it? Yeah. Oh, yes. I mean, absolutely. Unless there's other contraindications, there's no reason you couldn't. That class is a hot button right now in terms of both effectiveness, tolerability, how long do you stay on it, what happens, but also coverage, because it's so expensive. Increasingly, your insurers are going to be questioning what, how people are getting it, why they're on it, how long. But yeah, there's no reason you couldn't. There will be increasing financial support for that drug class for people for weight loss, for sure. It's very new. And so we're sort of figuring all of that out.
So give us a background, and maybe each state's different, but palliative care doctors, as you are, how would you help out if I have a financial problem with medications
Oh
or
yeah. Well,
treatments?
first of all, I would do nothing. I am helpless in that space, other than I would ask you, I ask everybody about everything. And like I said, I'm not going to shy away from talking to you about sex. I'm also not going to shy away from talking to you about how has cancer impacted your kind of financial distress, right? Because it has a lot of impacts on people's out-of-pocket costs, ability to work, so money in too, right? And finances are one thing we never talk about. And it matters because the more distressed you are, the worse quality of life you have, the worse you do. So what I do is I ask about it, or my social worker asks about it, or our nurse asks about it. And if there is an issue, we have financial advocates, and all NCI designated or comprehensive cancer centers or other places where you are getting treatment likely have what are called financial advocates in some form. Whether you know about it or not, they are likely there. And these are people that are very specifically trained to help get all drug assistance programs for patients, so that any gaps between what your insurance coverage is and what the out-of-pocket is, a lot of times drug companies will cover that, right? Or they will supplement some of it. They also will help with any charity financial applications that exist in your cancer center area, whatever, right? Also, any other charitable organizations. There's a lot of stuff that is very specific to specific cancer types or ages or whatever, that are there to help supplement in terms of finances. So maybe they can't just give you money, but they can, a lot of times what we'll do is pay bills for someone, pay their mortgage for a month, things like that. And what all my job is to say is, we've found that there is financial distress, and then have a conversation with or alert it to our financial advocates, who will sort of look through the drugs you're on, your cancer type, have a conversation with you. Also, our social workers do incredible outreach in terms of what other sort of financial support there is out there. And maybe it's something that's totally outside of your cancer center, but they will know of other organizations that are there that can provide it. Things like Living Beyond Breast Cancer or American Cancer Society, other huge organizations that have these charitable arms. All we need, my job is to find that it's there. And then there are experts at your cancer centers that will help guide you to what resources are available.
Thanks.
Because we don't ask about it enough, right? And financial toxicity of cancer treatment is real, and it causes a huge impact. So feel empowered to ask for those people, or what supports there are, if that's there. Again, there's nothing wrong with feeling financial toxicity during cancer. It is incredibly common, and we just don't acknowledge it.
Huge. We could keep you here all night, really, because between edema, weight gain, all of these side effects that we all are trying to move past to focus on living,
Yeah.
it's endless. And your cancer center or your supportive care center sounds amazing. I think that maybe we could put together a panel or something, because it's so great that you're all housed there. I would love that if we could even have a nutritionist. And Mark and I have tossed that around for a while, but this has been unbelievable. I wanted to end with, Mark, unless you have something else.
There's just one more question. It came in
Yeah.
3 different times. I don't
Okay.
know what this drug is. I know about Provigil as an example, but
Oh,
modafinil,
modafinil,
MODA.
those are all stimulants. Absolutely. If people were talking about that for fatigue,
Yeah.
they're all in that same class of the ones I was mentioning.
So give us those drugs again.
Okay, so Ritalin, or methylphenidate is the generic name of that, which is one. Concerta is another one you'll hear. Modafinil. You mentioned another one. I always forget. Strattera is one of them. There's a whole
Provigil.
bunch.
Vyvanse, yeah, right.
All of them, guys. so much of that, yes, they're all, consider them like sisters, right? What's going to matter is really your insurance coverage. Like some of them are generic, some of them are still branded, some of them are extended release, some of them are more rapid action. Have the conversation about it. And here's my very biggest point to tell all of you guys is that please do not feel like you just have to accept whatever symptoms are bothering you. Please do not feel like you are being greedy or asking too much or whiny by saying, I don't like this, right? And ask for help with it and bring it up and say, this stinks, because it breaks my heart. And I see it all of the time when you wonderful humans just say like, well, I'm not dying, so I'll live with X, Y, or Z. And like, that's not an equal comparison, right? And so don't just feel like you have to live with whatever symptoms you're suffering with. There are ways to help improve your quality of life with that. So feel empowered to ask about it and don't accept no for an answer, because a lot of times it's just pushing a little bit harder to say, well, let's help me understand that.
And that's huge. And do people need, that's exactly it. And so many people do say in our support group that they feel like their oncologist thinks they're whiny, or that they have to accept the weight gain, or it's their fault is a big one. Do people need a referral to see you? Does insurance cover it? How do they
No
go?
referral. We are all fully covered by insurance. So either cost you nothing or whatever your copay is, that's it. And you can absolutely, at any time, as often as you'd like, you can access sort of this idea of supportive oncology or palliative care. And I get it. And also I will never, ever fault anyone for saying like, my oncologist is the person that has the keys to my chemo or my targeted therapy or my immunotherapy. And like, I don't want to piss them off. Right. And like, first of all, you're not going to, you're lovely humans. But I get that feeling of like, I don't want to come across as whiny, or I'm not supposed to ask about this stuff or complain about this stuff. But that's why we're here, right? It is a team sport. And so please, please, please kind of get those resources and ask about it, because it will help you on a day-to-day basis feel much better.
It's
Fabulous.
awesome. Thank you so much. Like we said, 8 o'clock was our cutoff time. Questions keep on popping in about basically what
I'm
you
happy to
spoke
come
about.
back sometime or have other of my team on here, whatever, you know, Dan knows how to get me and I'll never say no to him. So
Can you send Dan that link, by the way, at the very beginning that you
the
were talking
link.
about?
Oh, about the personalized cannabis care plan stuff?
Yeah, because
Yeah,
we can
of course.
post that with Summer can post that
I will
with
happily do
with
that.
this talk. So
Yeah.
thank you so much. And I'm gonna pass it over to Dana before we get off to show the calendar, the weekly, monthly calendar. So
Dana,
Dana,
Hold on.
introduce yourself, please.
Yeah.
Hi, I'm Dana. I live in Westchester, Pennsylvania, and I was diagnosed stage 4 in November of 2020. So hold on, I'm going to pull up the calendar.
And I think Brooke was so shocked over how many groups that we have.
Amazing. You guys are incredible.
Yeah, so this week we have art and then explore with writing, but you have to that is a closed group, so just write to ALKtALK at ALK-positive.org, and that'll go to the director of that program. We are in the midst of starting another group. It just hasn't been finalized yet, so when it is, it'll come out and we'll put a blast that there's a new group coming out for writing. We have yoga and single alkies on Tuesday. Then we have chair yoga. Please excuse my dog barking in the background. Then we have new alkies on Wednesday, young alkies on Thursday, and mindset reset on Friday, which is fabulous. You know, we all need to think things a little bit differently, and Heather does an amazing job helping us navigate.
How do we access this calendar, Dana?
You go to if you go to ALK-positive.org and look under ALKtALK, you will be able to find the calendar and a direct Zoom link to this page. Anything that, unless it has a star next to it, it is on this page, on this room that you're in right now.
Which is in
So
the
everything
green
is
at the
in
top.
this room. But
And the
you'll see
ALKtALK
yoga and chair
link
yoga. What?
The ALKtALK link is on the top of the ALKpositive.org. It's on the
Yeah, so
banner.
this is the
Yeah.
room that you're in now. Here's yoga with Hanka on Tuesday, and here's chair yoga on Wednesday. So
And the
there
new
were-
Alkies is a brand new group. And I don't know if you want to give a little background on that.
on New Alkies, you said?
Yeah, since it's a new
Yeah,
group.
it was our moderator for that himself has been diagnosed less than a year ago, Adam. And he saw a need to, help people who are just newly diagnosed navigate all of this. So if you wanted to come and meet with people who are in that first year, that first difficult year, trying to figure out like what's going on, it's a place to come and talk. And then I also host ALK Chat, which is just a place to come and meet people. We have no agenda. We just kind of come and join the community so that, nobody ever feels alone. Just come and talk about whatever's on your mind. And young Alkie is for diagnosed under 50. Single Alkies is if you're on this journey and you don't have a care partner, like how do you navigate, asking friends for help or, being home alone, so you talking to other people who understand that situation and find out how other people make it work for them. Guided imagery is we listen to a guided imagery when we sit, we turn our cameras off and we just listen. And there's generally a presentation that we go through about like positivity, mind body connection. It's a really very it's a wonderful group. I think I hit on everything. And then I also run Death Cafe, where we come and we discuss topics that might be difficult, that you're on your mind, but difficult to discuss with your family, and kind of help you kind of process through that so that you can, if you want to talk to your family, you kind of are coming from a place where you've already thought it through.
Thanks, Dano. I'm past this summer. Do you have any other announcements, Summer?
I just wanted to say that this calendar was updated on Friday. So the website actually reflects the previous calendar, but tomorrow that will be changed. Evening book club was canceled. If you see this one, the correct calendar did come out in the email today. And has been posted in the support groups, but and the book club on Friday was switched from the 29th to the 22nd. So
yeah, we realized it was Good Friday, and I was like, I think we were gonna have a little bit of difficulty getting people coming on Good Friday, so let's just move it up a week.
Perfect. So those are there, and the website will be updated tomorrow. And then be on the lookout for our April calendar. We have some exciting talks coming up, but are still nailing down the dates for those. So that is it. But thank you all so much. Dana, do you want to unshare this, please? And we will see you again in a few weeks. Again, be on the lookout for the new calendar. Somebody joined Dr. Brooke down there. If you want to give a wave to her daughter and unmute yourselves and say thank you. This was such a fabulous talk.
Thank you, Dr. Brooke.
Thank you, Dr. Brooke.
Thank you,
you.
Doc.
Thank you, guys.
So
It was so
Thanks so
great.
much.
Thank
Thanks for
you.
having
See you
me.
soon.
Thank
Bye.
you.
Thank you.
Thank you.
Thank you
Good
for your
night, everybody.
time.